Well, good evening, everyone, and great to be here for our Family Domestic Sexual Violence Clinical Spotlight series. This is session 3, which is titled the Sensitive Inquiry Skills Development, Practical Strategies and Demonstration. So this is our third of 4 online education sessions across this series that we've been running on family, domestic and sexual violence over the past couple of months. Our final session is actually next month at the end of May or the last Wednesday in May, but we're really pleased to see so many registered and so many of you dialed in for this particular session. We've got a really fantastic session planned. I just want to say my name's Emily Leary. I'm the project lead with Western Victorian Primary Health Network on the Family Domestic Sexual Violence Project. And I'm joined by a couple of my colleagues on the screen here. We've got Sarah Hull, Project Officer with me, and also Jade from the Workforce Development Team helping to run everything smoothly. We've also got some fantastic presenters who I will introduce in just a moment. So we do just want to acknowledge the traditional owners and custodians of the unceded lands and waterways of what we know to be now as Western Victoria, and we do pay our respects to elders, both past, present, emerging, and for all time, and extend that respect to all First Nations peoples. We commit to working together in the spirit of mutual understanding, respect, reconciliation, and we also support self-determination for First Nations peoples and organisations. Sorry. So we just want to say that we do have upcoming events that you can have a look at, and it's important that we just share those with you this evening. You can view the majority of our webinar recordings on our PHN Learn YouTube channel. So check out the upcoming events on the screen at the moment, and you can register for these on our website. We'll also be putting the links for those in the chat for you. Excitingly, we've got our primary care conference coming up this year in Ballarat in October. That's going to be at the Good Shed in Ballarat. So on the 9th and 10th of October, we've got some fantastic keynote speakers locked in for that and lots of impactful education sessions. So please do register. They'll be open in early July. So when they're released, you can certainly register for that, and you'll be able to hear more information about our speakers and planned sessions. So we've got our Westvic PHN Learn and Network newsletter also up and running, and that's the best way to stay up to date with our education opportunities and upcoming events as well. So if you haven't received an edition yet, do subscribe via the link in the chat, or you can scan that QR code. Editions of that newsletter are released on the first Tuesday of every month. Also important to just always promote our health pathways online resources. So those are local, clinical and referral information for health practitioners. So do just make sure that you check that out and familiarise with that. We've also got a lot of family domestic sexual violence relevant health pathways pages available as well. So just a bit of housekeeping. In order for us to issue you a certificate of attendance, we do need to make sure that your name is accurately displayed on your login screen. If you're dialing in from a meeting room and your name is not actually on the screen, please do put your name in full in the chat so that we can ensure to issue you with a certificate of attendance. I do just want to say that the event is being recorded in full this evening in order to ensure that we capture the entire role play and case study based discussions that will help to demonstrate sensitive inquiry, which is what we obviously put down as our learning outcomes for this evening's webinar. So what that means is that during the presentation, our presenters are actually keen to engage and hear from you, certainly through the role play based discussions. So what we do encourage for this particular session is that when you're invited to share comments or reflections, please do take a moment to engage via the chat box, or you can raise your hand and reflect that way as well. Thank you also to those of you that have submitted case studies in the lead up to today's session. I believe we've got a couple to present and one at least that was submitted by an attendee, so that's fantastic. Look, important last note from me is to say that we need to ensure that you're aware that this webinar is being funded by a national pilot project called the Strengthening Primary Care Responses to Family Domestic Sexual Violence. And so what that means is we need to ensure to capture your feedback at the end and support future initiatives such as this going forward. So please do click the link in the chat at the end of the session, or scan the QR code there to open the survey, and then you can complete it when we've concluded. And just important to always set the scene before talking about a sensitive topic like family domestic sexual violence through the case studies today and throughout the session. It does raise issues for many of us, and so that's important to just let you know that you're not expected to share anything at all today that feels uncomfortable. At any point, if you need to step away or take a moment, you're welcome to do so. And we always remind you to approach the session with openness, empathy, and compassion for yourself and for others. So it's my pleasure to introduce our presenting team. We're going to hear from three wonderful people. Firstly, Dr. Melinda Gill, who's a general practitioner, works at Headspace in Geelong, and also works with us at the PHN as a consultant, and also has led research for us in the past and currently in relation to insights that we're keen to capture as part of the national pilot project. So it's great to have you with us tonight, Mindy. And also we're going to be hearing from Rochelle Winnan, who's been working in the prevention of gender-based violence sector for a long time, and has held roles supporting organisations to translate policy into practice, such as the Gender Equality Act and MARAM, and has also played a key role in delivering the Strengthening Hospital Responses to Family Violence project, which was running a few years ago. We're also going to be hearing from Penny Zakiel, who works at the Therapeutic Services team at the SAV Centre, or the Sexual Assault and Family Violence Centre in Geelong, and has held a lot, long-standing roles there, including counsellor, advocate, and team leader, and obviously supporting victim survivors at a senior level across the family domestic sexual violence health spectrum. I do just want to say that both Rochelle and Penny are also working as sexual violence integrators with the PHN's pilot project, and so they've been engaging with primary care providers for a little while now, delivering our well regarded family domestic sexual violence ALIVES training and support program. So it's my pleasure to hand over to the presenting team, and we've got Dr. Melinda Gill kicking us off. So over to you, Mindy.
Thanks, Emily, and good evening, everybody. Before I hand over to our family sexual violence specialists to do a deep dive into sensitive inquiry, I'm just going to give a very quick snapshot of some of the background content that we present about family, domestic and sexual violence as part of our ALIVES training package. So firstly, just to define family violence. So according to the Family Violence Prevention Act, family violence is any behaviour that occurs in a family or intimate relationship that is physically, sexually, emotionally or economically abusive, or causes a person to live in fear for their safety and well-being or that of another person. And as you can see there on the slide, there's multiple forms that family violence can take. Family violence is very common. So according to recent ABS data, 1 in 6 women and 1 in 6 men have experienced family violence under the age of 15. And over the age of 15, 1 in 4 women and 1 in 14 men have experienced domestic violence. So, and you'll also know that in Australia, 1 woman is killed every week by an intimate partner. Sexual violence is defined as any sexual activity that happens where consent is not freely given or obtained, is withdrawn, or that person is unable to consent. So it also can take a wide range of forms, not just rape or forced penetration, but any sexual act where there is coercion, pressure, or fear is involved, and can include acts such as stealthing, sexual threats or harassment, image-based abuse or reproductive coercion. Like family violence, sexual violence is also very common. And the same ABS research showed that 22% of women and 6% of men in Australia have experienced sexual violence, most of which occurs in the context of an intimate relationship and occurs also in the home environment, not necessarily by strangers, perpetrated on the streets, as we often hear in the media. Family, domestic, and sexual violence are not just social and legal issues, but they are critical public health issues because of the long-term and serious health impacts that they have on victims. So according to research, family violence is the greatest cause of ill health and premature death in women under the age of 45, and is the 7th biggest cause of ill health and premature death in women of all ages. Although we don't have similar research, comparative research for sexual violence, we know that sexual violence causes more severe and longer lasting impacts or trauma compared to other forms of violence. Because of these impacts, victim survivors attend general practices more often than those without lived experience, although they may not necessarily be identified as being victim survivors. And one of the many reasons, is that the health presentations are often quite complex or subtle. Of course, it's more obvious when there's physical trauma involved, but when there's psychological trauma or fear and control, the presentations can be quite diverse and include a lot of different mental health presentations, general emotional distress, chronic pain syndromes, and of course a lot of reproductive health issues as well. General practices are in an ideal position to identify and support victim survivors, notwithstanding many of the challenges that we have in being able to do so because of systemic or structural issues such as our funding model, being time poor, sometimes lacking training or feeling isolated or unsupported, and often not having those referral options that we need. However, despite this, our generalist whole of person care and other skills again make us ideal to be able to provide both an environment to enable disclosures and then provide long-term support. So that can include our active listening skills, our ability to handle complexity and have difficult conversations, and also work as a team and again provide that long-term holistic care that victim survivors need. The way in which we sort of summarise and structure the core skills that general practices need to recognise and respond to victim survivors in our training is called ALIVES. So that's an acronym, again, that we use to summarise the key skills needed. The A part of the acronym is about providing a context to enable a disclosure, and the LIVES component from the World Health Organization summarises how we can respond to disclosures. So again, to enable disclosures, we need to be aware, understanding that family domestic sexual violence are common. They cause serious health issues and that victims are attending general practice clinics often, and we need to create a place of safety within within our practices to allow them to share their stories. We need to be alert and recognise the red flags and clinical indicators, and when they are present, be able to sensitively ask using a funnel approach, which I'll describe in a minute. And after a disclosure, again, we can be guided by the lives response. So we listen, we inquire, and are directed by the victim survivors' express needs. We validate their story. We believe them, and we respond without judgment and blame. We enhance safety, and again, we provide long-term holistic support, which can include referrals to other services. Can't go on to the next slide. Oh, there we go. So the funnel approach is just, again, an approach to enable disclosures. So starting with some very sort of general questions about what might be happening at home, in the relationships, what happens when they fight or argue, or if any of the other family members might make them feel unsafe, before moving on, if indicated, to ask some more specific questions about that abuse or violence. So that's all from me for now, and so I'm going to hand over to Penny and Rochelle.
Thanks, Mindy. Good evening, everybody. It's really nice to be here, and I'm grateful for everyone that's turned up to be with us tonight in person or online, but during our live delivery. So we're going to be moving into focusing really on the, I guess, the hows of the sensitive inquiry part. We had a look at the A-Lives there with Mindy, and we're really focusing in on that inquiry and how do we do that when we're talking about FDSV or family domestic sexual violence. And that might be with adult or with younger people, patients as well. We just flick to the next one. Thanks, Rochelle. Really just an acknowledgement again, just to echo what Emily said earlier, that, you know, that talking about these kinds of topics can be difficult at times. We don't know what everybody's lived experience is, even in this space, let alone our patients as well. So just taking the time to do what you need to, either during this session or later if you end up doing some work in this space as well. 1-800-RESPECT is a number that you can call. It can be something that professionals can access to get some support in this area, as well as something that we can refer patients to as well. So a bit of an outline just to get a sense of what we're going to be covering tonight. We're going to start off with a bit more of an information-based part at the start. So looking at, why is it important to look at this? Why is learning about how to really sensitively inquire about topics in this area, why is that important for our patients? What are the barriers to asking sensitive questions? What are the principles of sensitive inquiry and trauma-informed practice that we can sort of rely on, even if we know maybe are not sure what's coming? We might have some example questions or some example statements that we might rely on that might feel comfortable for us. But really, what are the principles that guide our work in that area? And then how do we ask? So we will provide a few slides that have got some example questions and statements, just to give you a bit of a sense of these are the kinds of things that might feel most relevant in the moment. Again, and we'll mention this probably throughout, really in this space, authenticity is the key. So whatever it is that we're talking about, whatever examples we might provide, or things that might come up in the role plays, for example, take whatever it is with those principles of sensitive inquiry and that lens of trauma-informed practice, and make the words your own. You know, making it as authentic to you is going to be what's going to really build that connection and rapport with a patient. And particularly for people who have experienced trauma, they're going to be really highly attuned to things that are either authentic, or they're going to pretty easily pick when it's not. So choosing the words that feel most comfortable for you is really key. Emily did indicate that we're going to do, we've got a couple of case studies. One of them is a role play. That's for us. You don't have to worry about that. You can just watch. And then we're going to have a few reflection questions after each of those. And then if we get to it too, we've got a second role play that has a bit of a different scenario, different case study, bit of a different scenario that we'll sort of focus on as a bit more of a group discussion. Hopefully there'll be time for questions at the end. We'll see how we go. I'm going to hand over to Rochelle.
Thanks, Penny. Yeah, I guess it's really important to know and acknowledge why we need to be normalising asking about family, domestic and sexual violence. And I guess Penny and I have worked in this space for some time. So for us, it can seem second nature, but for others, we really acknowledge and validate that it can be quite tricky. But there are some really important aspects as to why we need to be asking. And one of them is really about reducing shame and stigma. If we can ask openly, we know that victim survivors unfortunately do carry a lot of shame that doesn't belong to them. And there has been a long kind of standing stigma or stereotype about family domestic sexual violence that we really want to start to challenge. So if we can be asking in a way that is really sensitive and open, we want to be ensuring that it's not coming from a place of judgment, and we really want to be validating and reassuring them in their experiences. Victim survivors also, as Penny said, are really attuned to your kind of behaviour or the way that you're kind of showing up. So signals that you're a safe, intelligible person is really important. So things like posters in your practice, maybe pins, on lanyards or stickers in consult rooms. Those are the sorts of things that we mean by this. And I guess the way that you approach your patients, and we'll talk about trauma-informed care, will kind of set you up in good stance for victim survivors to kind of start to understand whether you're a tolerable person, being really empathetic, being really mindful about your tone. Those sorts of things are really important. Increasing understanding of family domestic sexual violence as a health issue as well. So we know victim survivors may not be aware of the health issues that do come alongside experiencing trauma. And so being able to, relay those back to victim survivors or patients means that it can kind of affirm their experience. And it means that they can kind of recognise that, they're not going crazy. There is some explanation as to why you may be feeling the way you are, in the absence of kind of any other real obvious signs of physical health as well. So that's just something to keep in mind. It removes the burden from patients having to take responsibility to volunteer their information increases the likelihood of disclosure as well. So by asking victim survivors, even if you don't actually receive a direct disclosure, doesn't mean that there has been a failure, because quite often we know that victim survivors won't directly disclose in the first instance that when they've been asked, but they will know that when they walk out of your consult room that they have picked up on something, and perhaps you're the first person that has ever asked them. It takes a lot of courage for a victim survivor to tell their story. So it means that they probably will be more likely to tell you, when they are ready to disclose. And I guess also it provides opportunity for earlier intervention, support and better patient outcomes. The earlier someone can disclose and have that kind of validation and reassurance and receive that support, the better the outcomes are going to be for them, whether that be safety planning or, if they're disclosing that they may be planning to leave a relationship, we can work with them as to how we can support them. So, they're just kind of a couple of things around why we need to normalise asking. There's many, many more, but it's just kind of a start there. And then what do victim survivors say? So we know that normalised inquiry often feels supportive rather than intrusive. So kind of helps to de-individualise inquiry and make it clearer that healthcare providers understand this as an issue and that it is important part of a person's health and well-being. So yeah, we're not signaling this person out or judging them. It's just about being able to understand, that we want to normalise this inquiry. I did mention that even if a patient doesn't disclose today, asking gently and routinely will increase the likelihood of a future disclosure. And I mean, if you don't receive that disclosure and you kind of, routinely ask that patient as they come in, just gently, if you're still noticing on some, signs or some symptoms that something might be going on, they will most likely disclose to you, because it takes a lot of courage to disclose, and building that rapport and trust is really important in terms of victim survivors. Patients often remember being asked and come back when they need help. Again, I think I've talked about this, but it is a really key piece to receiving a disclosure. The way that somebody is asked and the way that somebody is responded to really does make or break whether somebody will engage in support. And what we know is if somebody has had, maybe not the best response, or they haven't been believed, or it's kind of been, pushed to the side, they're less likely to disclose again. So we need to take these disclosures really seriously. And using clear, direct language helps patients feel more confident, particularly when we're speaking about sexual health and well-being as well. People are really tuned if you are coming across as kind of nervous or awkward to talk about or ask questions about sexual health. They will pick up that, it's uncomfortable for you. It's going to be uncomfortable for them. We need to really start, just kind of normalizing asking about sexual health and the conversations that we have around them, particularly with young people. They will be less likely to want to talk to somebody who's kind of awkward about asking these questions. So, that's just important to kind of take into any kind of inquiry that you might be having around sexual health.
Okay. So just as we move into the barriers, what are the kind of things that we hear a lot in the training sessions? We've really tried to capture some of those things here tonight because we recognise the themes that come through from your peers, the GPs we see and practice nurses who are trying to have these conversations and are working through how they might inquire. We really recognise that, first of all, this is not an exhaustive list by any means. These are the main kind of themes that come up. We really invite you, if you have a glance at that and you have a look at the kinds of things we're talking about already this evening and think, I had a particular question or I had a particular concern that I was really hoping we could address here tonight, by all means, please feel free to add to this list. So as Emily said earlier, pop things in the chat, pop a hand up and come off mute and have a chat. We really want to make sure that you leave this session feeling like your concerns and your questions have been answered, and we've targeted them to the kinds of presentations that you might be seeing. So I guess in that same vein, we also recognise that, asking questions or putting ourselves out there a little bit, particularly in spaces with topics like this that might be a bit less familiar, can feel pretty daunting. As Rochelle said earlier, both of us have worked in this sector for a long time, and it's taken us a long time to get really comfortable talking about these things. And we know from the GPs and the other health professionals that we're seeing in the other trainings that we're delivering, that there is a real want to be more confident and comfortable talking about these things. So I guess I kind of feel like use us while you have us. If there's questions that we can answer, or things that you want to have a try of, or just work out how to word, by all means, please feel free to join in tonight. Looking at this list then, fear of getting it wrong is one of the main sort of things that comes up, I think. What if I say the wrong thing? What if I damage that relationship that I have with this person? What if that person gets angry? What if they become upset? And I think really what we always want to say in this space is there's no such thing as perfection, that there is space to repair. If something does go a little bit awry, if someone does have a bit of a reaction when we ask a question in some way, that's actually okay. We can pretty easily repair that. We know that you are having to have awkward conversations, and things can go awry in other areas as well when you're talking about someone's clinical health. It's the same kind of thing here. And we will go into that a little bit further as well about how we might deal with things like rupture and repair. Fear of escalating risk. This is something that comes up a lot, both in the trainings that we do, but also when, the services that we work for, we have a number of professionals calling from time to time for secondary consults. And this is a real concern around, what if I ask the wrong thing? What if I say the wrong thing and somehow I end up increasing that person's risk or triggering their trauma? And we kind of wanted to just do a little bit of a true or false here, just to get a sense of what might be sitting in this room if people feel like they want to respond here. So our first question is, if I ask about family violence or sexual violence in the wrong way, I'll somehow accidentally increase that person's risk. True or false? If anyone feels like adding something in the chat. Also okay if people don't want to at this point. False? Yeah, absolutely. Thanks, Jason. Yeah, I'll have one caveat. Unless the perpetrator is in the room, there's no words that you can use or question that you can ask that is going to increase a person's risk. A person's risk is increased when they make a disclosure because suddenly somebody else knows that information. But there's no way that you can ask it in a way that's either right or wrong that's somehow going to increase their risk. The other thing that we get to around, particularly as Rochelle said, talking about sexual health, and then if we think even with young people talking about consent and protected sex and all those kind of things can get awkward sometimes, or are things that maybe we are not so confident in approaching. One of the other statements that we've got here, or questions that we have, is if I give too much information about sex and sexual health when I'm talking with young people, or I open a conversation that leads to questions that I can't answer, maybe I'll do more damage. I might put ideas in their head, or they'll be too uncomfortable and they won't want to share any relevant information with me. True or false? Thanks, Jason. Yeah, it's false. Understandable, but false. So a couple of things on that. There's lots of research now that shows that young people who have access to really comprehensive sex and relationship education, and also have access to adults and a number of different adults that they can have open and honest and robust conversations with about their sexual health and relationships, not only are those relationships more likely to be safer for them, they're more likely to actually delay their first sexual experience and feel more confident going into those. So it's just good to know that actually having those upfront conversations, really can be really helpful for young people in particular. And also that, again, I think because the literacy around these things is increasing, there's lots of downsides to social media and 24/7 internet access, but there's some positives as well. Young people tend to be pretty open. If we can be open and clear and direct with our language, we're naming things correctly, we're not umming and ahhing or beating around the bush, they pretty well will respond in kind, and are actually pretty literate about their own sexual health and sexuality, and usually will respond quite well. A lot of the research sort of says if we are upfront and open and honest and clear on what we're asking, they will be too.
Yeah, Penny, I might just jump in, quickly about this one as well. I think by modelling having these conversations with young people in particular, but also adults, we want to be modelling that this is, something that we need to be talking about. We want to start to break down that kind of stigma and taboo around sexual health being, a fundamental human right. And we need to, I guess, just start to kind of dismantle some of those myths. So yeah, because otherwise young people will access this in other ways. Yeah.
Yeah, that's a downside to it too. There's a lot of other sources for them to get much less reliable and correct information, for sure. Yeah, thanks, Rochelle. It's a really good point. The third point here, the awkwardness in raising certain topics, is probably not dissimilar in a way. So particularly regarding sexual health. So either it's not something that was a focus of, medical education, potentially, particularly having how to have the conversations, doing the clinical tests and understanding diagnoses and things, for sure. But sometimes I think that having the conversations, and the fact that there is so much greater literacy these days too around things like consent, pornography use, safe sex, sexuality, all of these things, it just adds another layer to something that, if we're not familiar, is going to add another layer of awkwardness or second guessing. So I can absolutely understand why it's something that we may tend to try and skirt around or avoid. Also thinking about considerations for particular populations, how might we change our language, or how might we think about this sensitive inquiry and asking certain questions of people who may have some sort of a different experience to ourselves, or who may have a different understanding or language. So young people definitely, but people also who have come from cold or refugee backgrounds as well. Anyone who's experiencing living with disability, particularly, I suppose, cognitive impacts, First Nations people, LGBTIQA+ populations. How do we make sure that our language is accessible and inclusive and understandable and clear? And we will look specifically at language in a moment, but really just making sure that we're not using too much jargon, that we're being really clear, that we're sort of checking in and making sure that the understanding is there with people as well. And then I think the final barriers that we see a lot, we get asked a lot as well, is sometimes I don't want to ask because I'm not really sure what the answer is going to be. What if someone says something and I don't know what to do with that? And again, really, really understandable, particularly in an area like this. Really wanting to provide that reassurance that you don't have to have all of the answers on the spot. And we talk about that even when we're doing the more foundational FDSV sessions with the practices that we've been to this year. Consult. Any of the services that provide support for people for family and sexual violence in your local area also will have the capacity to provide secondary consults. But also equally just having that really human response and saying, you know what, I'm not really sure where is the right place right now, but we can work it out together. We're really kind of demonstrating, I suppose, that humanity, that actually we're almost removing that responsibility or that obligation for us to have all the answers all the time about everything. I think particularly, the things that we hear from GPs and nurses in clinics, the amount of things that you're supposed to have knowledge about, as long as we can show that we're willing to work on it with that person, we don't have to have all of the answers at our fingertips right there.
And Penny, I think it's also important to note as well, unless there is a child or an adult that is at imminent risk, often you can work together to decide what the next steps are, and giving the victim survivor choice and agency over what they want to do is really important, because we want to also demonstrate the sharing of power, because living in situations where they're experiencing control, they have really, really often had that power stripped from them. So being able to give it back and demonstrate that also will increase you to become a tellable person into the future as well with them. They'll build much more trust when you're able to give those options. Yeah.
Absolutely. Are there any other barriers that anyone's got sitting with them at the moment that they're thinking, what about this kind of situation, or what about this sort of presentation? If any of those come up at any point, please do feel free to throw a hand up or come off mute, or just pop it in the chat so that we can make sure we address it too. Okay, so we might move on to the next slide then. So we're going to start looking at, all right, so what are the principles of sensitive inquiry? What are we thinking about? How do we guide the work that we do in this space? Initially, so Rochelle touched on this earlier, but routine. If we make the sensitive questions that we're going to be asking about these kinds of topics more routine and part of standard consultations, it goes a long way to de-individualizing this for a person. So it's not suddenly something that that person is thinking, why am I being asked this? What is that? Why are they asking me that? What is it about me that's making them think that? Am I being judged? Is there something that I'm putting, some signal that I'm putting out that suddenly everyone knows I'm in this position? And again, you know, if we think about the stigma and the stereotypes around who experiences these things, the victim blaming that historically has occurred, you know, throughout our media, but pretty unanimously through society as well. And also, I suppose, if we think about that from a risk perspective, you know, if someone has a fear that they are being targeted for these questions for some reason because there's something about them that is obvious to other people, that's also going to be something that's going to make them feel quite that their risk is increased. I'm not hiding this, because generally people are really good at not disclosing these things and not showing that something is wrong, because that's the safest thing for them to do at various points. So really, if we can make our questioning as routine and part of our normal standard practice as we can, the better. And that doesn't mean that it has to be all of those standard questions that we would ask somebody in a first consult necessarily. It can still be something that we allude to as this is a routine kind of question, or I would ask any of my patients this, to help normalize this process and help the patient to see this as you checking in about a person's whole well-being and health. Using brief, clear, and gentle language. So keeping our questions simple, direct, and framed by care. So that use of clear and correct language, whether that's talking about, you know, various parts of the body. I can just see in there too, sorry, Emily, taking away stigma. Yeah, absolutely. Yeah, definitely. Thank you. So using that clear, correct language might be around talking about certain body parts or talking about anything to do with genitals in particular. If we're just naming things properly, helps the person feel confident to do the same. It will increase someone else's awkwardness if we appear awkward. And this is generally going to be something, if someone was considering a disclosure, it's something that they're really nervous about anyway. So anything that we would normally do to put patients at ease is again, really important here. The clear and gentle language is also around, you know, can also be examples like you're reflecting the patient's language and wording back to them to seek clarification. That means that we are showing that we're attuned to what they're saying, but it also helps us make sure we know exactly what it is that they're naming with that language. Another thing we're going to look at with language in a moment is the idea of behaviourally based questions as opposed to label-based. So we would generally not ask somebody, are you experiencing family violence or have you experienced sexual assault? Because that assumes that the person has the same understanding of those phrases as we do. And all of the research and all of our anecdotal experience as well is that that's just not the case. So many people, I work for an organisation called the Sexual Assault and Family Violence Centre, and still some of the questions that we get most regularly are these things that have happened to me family violence? Is that really sexual assault? It's not something, I think, you know, these things are generally, they're just so not well understood and pretty terrible. And so most people don't want to think that what has happened to them would fall under those umbrellas. So when we can be more specific in our language and more behaviourally based, less label based, we're much clearer in what we're asking for. It also means that the questions we're asking are going to be more easily understood by people for whom English is not a first language, or anyone who's got any kind of cognitive impairment or neurodivergence even, all sorts of things. It's just going to mean that we're much clearer in what we're asking. Transparency around confidentiality. I think sometimes when we see confidentiality, we almost have this hope that we're going to be able to say to everyone, a blanket level of absolutely everything you tell me is confidential. And what we know, particularly if we think about trauma-informed care, is actually it's about giving someone informed consent to make a choice about what they're telling us. So being really clear about confidentiality and then what the barriers or what the limitations are on that and what your scope is to keep everything confidential is really important, because it just gives that person the agency back to decide how much they want to disclose and when. As Michelle said earlier, we know that with these kinds of trauma in particular, these interpersonal kinds of trauma, family and sexual violence means that that person has had all choice and control taken away from them in these situations. And so we don't want to do anything that's going to mirror that dynamic for them. So anything we can do to show that we are giving them that choice back about when they disclose, about who they disclose to, how much they say, whether they want to seek support or not if we offer, all of those things are going to help in that space. And so that idea around transparency, around confidentiality, but also around what we can offer, what we can support with, and where other services or supports might be more appropriate or more helpful is really key to giving someone that choice. And authentic rapport is key. So I really like that line, humanity over perfection, because rupture and repair is possible. There's something about, I think we do hold ourselves to a really high standard, particularly in this space, because there's a fear that if I say something wrong, I'm going to make it worse for this person. But actually, if we're really authentic, and sometimes we maybe do stumble over our words, or we have to correct ourselves, or sort of fix something up, it really actually is just bringing our humanity to the fore. And so it's actually removing that power dynamic or power imbalance that can occur when people come to see a doctor. You're an expert. There is a power imbalance, no matter how focused on equality and breaking that down we are. So anything we can do in that space to show that we're just as human as they are, and we are, particularly around a topic like this, engaging with them on that human-to-human level, is really great. It also, if we're not perfect, it also gives permission to that person to not feel like they have to be perfect either in their explanations or in how they present. So that authentic rapport is really, really key. Okay, that one so far. Thanks.
Thanks, Penny. So following on with all of this in mind, we want to kind of explore what makes someone a tellable person. And we've talked about some of these themes around, tone and the way that we're kind of presenting in front of victim survivors. But we want to really unpack these principles of trauma-informed care, and hopefully it'll give you a bit of a roadmap as to, what we need to be considering to be trauma-informed. And we want to be seeing trauma-informed care as a lens that we put over everything. Working in this space, it is just something that we automatically do. It's something we can't switch off. It's a lens that we need to be kind of adding to this kind of health issue. So the first one there is really about prioritizing safety and or hypervigilant coming into kind of a clinical space or having clinical interactions. So, it's important that, we're trying to make our environment or our space as welcoming as we can. And I said, again, when we have those, pictures on the walls and different things that we might do, just to kind of, instill a sense of safety in victim survivors as well. And we know that a strong sense of safety increases the likelihood of disclosure and ongoing engagement. So it's a really important one to consider. The next one is really about fostering capacity to soothe physiological arousal. So we really want to look at supporting regulation. We know that trauma really does impact the nervous system, and we don't really know, there's no really one way that this might present in a patient or a victim survivor. It just depends on kind of what response they might be having. So, for example, they might become overwhelmed, they might shut down, or they might dissociate. They might become a bit frustrated. Those are all the sorts of things that might present. And it's really important that we know or have some kind of tools around how we can regulate our patients, because we know that once they are regulated, they're able to think and communicate and consent to sharing information as well. So that's also just something that we need to consider. We don't really want to be probing somebody who is overwhelmed or is hypervigilant. We need to be kind of creating space for that. We want to validate the person and their perceptions. So another really important piece, many victim survivors have experienced disbelief or minimization or blame, even self-blame. So we want to really look at validating their experience. We know this does reduce stigma and increases trust. So it and also in turn makes future help seeking more likely. So that's just something else we need to be considering. Validation can be as simple as things like, I believe you, it's not your fault, you're safe here. Collaborating and empowering, as kind of Penny spoke to, experiences of interpersonal trauma and family domestic sexual violence always involves a loss of control and power imbalance. So we need to really start to look at restoring this kind of autonomy in victim survivors. And this can be about working with them, giving them choice around how they might want to move forward. So we want it to be collaborative. We don't want to be kind of posing anything on top of them, giving them that kind of option to, follow through with a referral, or, they can refuse referral. Those are the sorts of things we need to just keep in mind. We need to really be able to control ourselves. If people aren't taking on referrals, there is often lots of reasons for that. So we need to be mindful of that collaboration and empowering piece. And also connect and stay involved. Disclosures are often gradual, and they may not happen in one consultation. And even as practitioners, disclosures can, or they usually uncover over multiple sessions. So that's just something to keep in mind, just managing your expectations that that's not something that often will occur. And they can feel kind of less comfortable and sort of more uncertain for us as clinicians, because we want to know more and we want to support more. But it's really important that we're not probing too much, because then we'll cause the victim survivor to shut down, dissociate, and potentially become unregulated because of the way that we might be trying to kind of probe too much or get too involved. It's just about balancing that power as well. And we'll be talking a little bit more about particularly connection and staying involved in session 4. So do keep an eye out for that as well. And also it's just important to note that these principles have come from the RACGP White Book. So please do have a look at that in more detail.
Thanks. So we talked just before, there's a couple of slides here that we will kind of go through quite quickly because you will all get a copy of these sent to you afterwards as well. So don't feel like you have to remember all of these things, but we're moving it here. We've got a few slides with some examples. And really this is just to give an example of what we mean between the difference between those label-based questions and the behaviourally specific questions. So rather than saying something like, are you experiencing domestic violence? Has anyone at home ever made you feel afraid or controlled who you see or hurt you physically? We're really asking some specific questions so someone knows exactly what we mean. Rather than have you been sexually assaulted? Has anyone ever done anything to you that sexually that you didn't want to or that you didn't agree to? One of the really obvious sort of ones that we hear about too is non-fatal strangulation. So has your partner ever strangled you? Or has anyone ever has your partner ever strangled you? We know that actually most people associate the word strangled with actually being killed by strangulation. So most people will say no anyway. Rather, has anyone ever put their hands around your neck or held you in a way that made it hard for you to breathe, even during sex? Unfortunately, choking and strangulation is increasingly common in pornography and is increasingly being seen as an expectation as part of regular sex for young people all the way through the age spectrum. So just having some language around that makes it really clear what we're asking. I'm working on another project at the moment with some women from refugee backgrounds. And we're trying to create some resources that are talking about how we can ask questions in a way that is going to be really clear for them. And even some of the questions that we would ask when we're doing risk assessments with people coming to our services, we might ask things around this and say, ask about choking and things. When we asked these women how they would respond to that, they said, oh, choking. Oh, I thought you meant on food, even though that was nothing to do with it. That was the word association for them. So some of those things are just a really clear reminder for me sometimes about how we make sure that the language we're using is really clear, that we make sure that the words we choose are really understood by the person that we're asking, to make sure that the information that we're getting is accurate. We're not going to spend too much time on these questions. We've got some slides that will actually just look horrifyingly text-filled around these. But really just we've tried to center these slides around what are the main barriers and what are the main kinds of presentations or kinds of questions and statements do we commonly get questions around. How would I ask that? Or what do you mean? What would I say in those spaces? So, for example, Rochelle was talking about how we normalize and how we ask these questions in a really routine way. I ask everybody these questions because of safety. This is not just you. I ask all of my patients about this. Or for rupture and repair here, I apologize. I think I worded that question really poorly. Do you mind if I ask it again? We've got lots of different topics here. So we've got one here around sexual wellbeing and consent and how we might go about asking some of these questions. And the next couple are also, so some of these you might notice, some of them might come up in the role play. Again, one of the things that comes up a lot is I think I've identified some indicators here that something's not right, that there might be some safety issues with this person, but I can't. Their responses has been, it's been really ambiguous. I can't tell. How do I clarify that without making things worse? So we've got some examples for that as well. And then again, in that space of not really sure what to do here, how do we address that? Some statements and some things that we might be wanting to say to people to sort of work on that together with them. So they are things that you can have a look at in your own time and reference them, and hopefully they will give you a bit of a pointer about responding in those kinds of situations. Okay, so we've got a couple of case studies here. We're already at 7:30, so we'll see how we go. This first case study, thank you very much to the attendee who submitted this for us. We have based the role plays that Rochelle and I are going to do around this first case study that was submitted. And the way we're going to do it is we're going to have a look through the case study first. So we've all got a sense of the background and the presentation for this patient. And then the first two role plays that we're going to do will demonstrate a couple of alternate scenarios about where we might get to based on the question that was asked to establish some safety with this client. So this patient, if we move to the next slide, just so we get a sense of what's happening. Thank you. So just as a bit of background here, we've got Jane is the patient, a 48-year-old woman who presented for management of poorly controlled hypertension. During the consult, she appeared anxious and tearful when discussing sleep disturbance and headaches. When asked about stresses, she briefly mentioned things at home aren't great, but quickly redirected the conversation back to her blood pressure medication. Jane has attended intermittently over the past year with somatic complaints, including migraines, insomnia, abdominal pain, no documented disclosure of family violence. She's financially dependent on her partner and has 2 teenage children. No visible injuries noted. She's declined mental health referrals in the past, stating she's just tired. And the assessment and where this got to for this particular case, possible indicators for family violence being observed. And then we get to this final question, a check-in question around general safety, because we note that there was something mentioned at the start, but that the patient redirected the conversation. So the first 2 role plays we're going to do are going to start with that final question. So it might feel a little bit abrupt because we're just going to jump in with that. We're going to have a look at the first role play is going to be, how do we elicit some clarification around risk and concerns we might have there when those responses are a bit ambiguous. And then you can see that Rochelle's popped in the chat there. We've got the principles for sensitive inquiry there, just thinking around, are there any of those that you're noticing, hopefully. And we're going to have a few reflection questions after each role play. So if everyone's okay with it, we're going to kind of jump into that and see how we go. Rochelle is going to be Jane, and I'm going to put my best GP voice on and see how we go.
Thanks, Jaden. You could probably stop sharing now as we, yeah.
Beautiful. Okay, so Jane, I just want to check in again. Do you feel safe at home?
Yeah, it's fine. Why?
Oh, why? Yeah, good question. Firstly, I'm really glad to hear that you do feel safe. I suppose why I'm asking is, you've mentioned a number of symptoms in today's appointment that would suggest to me that you might be experiencing maybe more stress than usual. So we've talked about the insomnia and the headaches. The blood pressure is pretty elevated too, particularly more than normal. And I suppose I just want to let you know that it's completely okay for you to talk to me about anything that might be happening in your life that might be contributing to that stress or the pressure that you're living with. Is there anything that you feel would be useful to talk about?
I don't know, like what?
Yeah. So, for example, you mentioned earlier that things aren't great at home. And I suppose I'd really like to check in with you about what not great might look like.
I suppose yeah, look, it's nothing really. My husband is just under a lot of pressure with his business at the moment. It's been really up and down, so that stresses him out. And then, he gets really angry easily. And I hate arguing and stuff. That's just all I meant.
Okay. Yep, I see. I mean, that does sound pretty stressful for you too then. How do you manage that?
Well, I just try and take more of looking after the kids, I guess, and managing the house staff, making sure there's less for him to have to worry about. I just stay out of his way, and the kids know to keep out of his way as well, so we just don't set him off. But it's fine. It always passes. Yeah, I guess that's definitely why it's just not great at the moment.
Yeah, no, that makes sense to me. And I mean, wow, that really is a lot for you to hold. And yeah, I can understand that that's what not great looks like then. There's just something else I'd like to understand a little bit better. Something else that you mentioned. Is that okay? Yeah. So when you mentioned you stay out of your husband's way when he's angry so that you don't set him off, I guess I was trying to put myself in that position when you said that, and it made me think, if I was to say those words, that would probably be because I was feeling a bit nervous or a bit scared about someone's behavior or their reaction. to something for whatever reason. And I don't know, is that what it feels like for you too, or do you mean something different when you say that?
Oh, it's been slow for a few months. So money's just been really tight. That makes it hard too. And yeah, I guess what you're saying like that, I know what you mean. Yeah. Maybe you said nervous. Maybe nervous is probably a better word rather than scared when he's like that. But again, I always manage, it always passes. So yeah, it's fine.
Okay. I hear you telling me that that you're feeling like you're handling everything at the moment and things are okay, and that's good to hear. Just know that if anything ever changes, or even if it just keeps feeling hard like this, or if things feel like they're getting worse, that you're always able to talk about it here and make an appointment and have a chat about that if you would like to.
Yeah. Okay. Thanks.
Okay. So I know that we earlier booked in some tests and things done. So if you're able to get those done in the next couple of days, they'll send me the results in time and we'll be able to have our next appointment. I think we had booked that for a week's time. So that should be fine for then. If anything changes, you can always call the clinic and have an earlier appointment. But otherwise, I will see you same time next week.
Thanks. See you next week.
Okay. Role play 1. Jade, we might just pop the reflection questions. Thank you. Just curious about, we've got 4 questions there, and just thinking about what kind of things did you notice when you watched this? Do you think that conversation went well? Anything that you might have done differently? Do you think there was anything that was missed? Particular ways that you think you might have phrased some of those questions or statements that might be a bit different? And at any point, are there any barriers to asking that you would need to address? Any spaces where you thought, oh, I don't know that I would feel comfortable to ask that or not? Just curious about what people think. Just no comments on the acting skills. Absolutely. Feel free to just come off mute if you'd like to, or pop anything in the chat that you're thinking. What was that like for you, Rochelle, as the patient?
Oh, well, other than, the terrible acting that was happening from I think it felt really good. I think you balanced things well. I think you were able to kind of funnel it in a way. I was being quite ambiguous. So you do have to, try and find your groove in terms of what you will pick up, like pick and take into, that funneling approach. But yeah, I think from my perspective, it felt pretty good.
And I think, one of the things we noted too in this was, that it's sort of an example where we've got to a place where we've identified that things are clearly not going very well, but there's nothing that has been indicated that would make us think, okay, there's imminent risk here, or we are now responsible for doing something immediately. So it's an example of where actually having that conversation, having it in a supported way, and also allowing there to be an end point to it that the patient chooses, means that it's something we can pick up again, and that we really proactively then booked in that next appointment to allow us to sort of keep touching base with that person. I'm just having a look at Emily there. I often just say, what do you mean by that, when I'm a bit stuck? Yeah, in response to not wanting to say anymore. Absolutely. Yep. But I think that putting yourself in her shoes is a helpful technique. It may make it easier, feel safer to explain what she means. Yeah, look, sometimes it really is. When it's, it helps you maybe make a suggestion that you think might be occurring without making it about the person. Oh, I think I would feel like that, but always that check-in. But is that what's actually happening for you? Because that also gives them the chance to either agree or say, no, it's not that at all. Examples of clarifying questions, placing the patient as the expert of their experience. Yeah, absolutely. We always want to make sure that we are giving them the opportunity to tell us what it's like. We're not telling them, and coming from a place of care and concern. Thanks, Michelle. I'm just looking at the time. I'm thinking maybe we'll just go on to the next one. Rochelle, how are you feeling?
Yep, let's do it.
Feeling all right? Okay. So this role play starts at the same point. So this is just an alternate about how this, asking that same question at the end might prompt a different scenario. And we're going to see a little bit more of a possibly a rupture and repair here. So
Do we want
again,
to stop sharing, or do we? Yep, great. Thanks, Jade.
So again, Jane, I just really want to check in again. Do you feel safe at home?
Yeah, it's fine. What are you saying?
Oh, I'm really sorry. I didn't mean to imply anything. I'm asking because the symptoms that you've described that we talked about earlier, and what you said about things not being great at home can sometimes be linked to stress or feeling unsafe. I would ask all of my patients about this, but I'm sorry I didn't explain that a bit more clearly earlier.
Oh, yeah. Okay, well, yeah, I guess things have been rocky with my husband recently, but when you asked about being safe, that kind of sounded like you thought I was being beaten up or something. And he'd never do that.
Mm-hmm.
It's just normal marriage stuff. He has, heaps of pressure at the moment. That's all.
Okay, that's great. And thanks for clarifying that for me and for letting me know how it sounded when I asked you that. That must have felt pretty confronting. Can you tell me a little bit about what rocky looks like for you guys?
Well, as I said, he's, got his own business and it's super busy. So, yeah, it comes with a lot of stress and, he can get angry and frustrated and can kind of just be hard to live with when he's like this. So, like, even just me spending a bit more money, on groceries than he expected can set him off. And the kids and I just stay out of his way when he's like this because, yeah, it's not fun.
Yeah, no, absolutely. That sounds actually really stressful and like it's a lot for you to manage. I have no wonder that your sleep has been impacted, and you said there are times you've been feeling anxious as well. Can I just check in again, hearing you say that around, not wanting to set him off and things, do you ever feel afraid of him when he's like that?
No, why would you ask that? He's my husband. I said I wasn't afraid.
Again, I'm sorry. I'm really sorry, Jane. I'm really not trying to imply anything or to make any judgments here. Do you mind if I try and maybe ask that another way? I'd really hate for you to leave here today feeling concerned that I was judging you or not believing what you're saying to me. Can I ask that again?
Oh, look, it's okay. I guess I'm probably on edge and a bit stressed too. And you've never asked anything like this before. So I just don't know really where this is going.
Yeah, no, absolutely. And that makes total sense. I guess where I'm coming from in asking you these questions is really just thinking about, as a GP, my priority is always thinking about my patient's well-being. And obviously that's physical health. And we've been talking about those physical symptoms, but it can also include things like what their day-to-day looks like. So maybe that's work or family and home, all of those kind of things. Anything really that might be contributing to higher stress levels or extra pressure, because those things can have a real impact on those physical health symptoms that we're seeing as well. Have I explained that a bit better about why I'm asking?
Yeah, I guess I do understand what you're saying, but I'm not afraid of him. There's just a lot of yelling and sometimes, but it always calms down. It will go back to normal soon, like, because it's happened before. I can handle it until then. Things are okay. Yeah.
Okay, that's great. Thanks for telling me that. And, I'm glad to hear that. I guess just know that if that ever changes or you ever feel like you would like to talk about any of this again, you are more than welcome to, if you want to.
Yeah, thanks. I will.
Okay. And then we would again probably do the same, booking an appointment for test follow-up, but it also gives us a chance the following week just to check in and see how that's going. And then again, that space, thanks, Jade, of having a really sort of proactive check-in. I want to check in with you again. I care about what's happening here and how this sort of develops for you. So again, we're going to look at this like similar kinds of questions and just think, what was that like to see? I think the rupture and repair is a space that a lot of people, all of us included, will do a lot to avoid the potential of. But I guess, given the risks of not asking about these kinds of things, it's just around thinking, how can I navigate that if that does happen? Is it, how can I explain that? How can I put that person at ease? How can I sort of try and get us back on track? Help explain things, because generally I think what we'd probably be seeing in that space anyway is a bit of a misunderstanding, or, as Jane mentioned, oh yeah, I'm stressed too and I don't really know where this is going. So it really gives that opportunity to clarify. I'm just curious about what people might have noticed or what you think. Would you have done it differently? Thanks, Sarah. I can see the comment you had from before as well around mentioning if anything changes, we can chat again. That's good. The patient, Jane, will walk away from that appointment knowing their doctor is a tellable person in the future. Yeah, hopefully they will.
Yeah, sure. I think also just remembering too that, and something I think you did really well, Penny, is Jane in this situation started to become, she was starting to become a bit overwhelmed and a bit frustrated, and using that principle of kind of soothing, like your tone changed, you become calmer, you apologized, you were able to kind of acknowledge or name that, oh, sorry, that came out wrong. It actually does just go such a long way to kind of share that. Yeah, you don't have to, it doesn't have to come out perfect each time.
No, that's right. None of us are perfect. I'm looking at the time going, we've got 2 more to do. So I'm wondering if there might even be maybe less time to stop in between the next 2. But just so that you get an experience of seeing what, we've got a couple of things. These ones, the next 2 will basically be what might happen at the follow-up. So one is going to give us an example of what we're maybe identifying something that's a bit lower in risk, still some risk, but maybe lower in risk. And then the second one is a bit higher. So we might sort of do one and then almost the other. Again, it's the same kind of questions, but I think just having that example that you can go back and watch, you could then go and ask yourselves those questions. And we will send information about the second case study to everybody as well. So you won't miss out on that information. We will send that to everybody with the slides. Okay, Rochelle, right? So we're just starting. Thanks, Jade. We're just starting the appointment. So got those test results. They all look normal. That's really good to hear. I guess now that we've sort of had a look at that, I really also just want to check in about your stress levels and what's happening at home. How is all that going?
Yeah, look, it's still pretty intense at home. Things haven't calmed down as I'd hoped they might. I actually started to look up relationship counselling, but when I did that after our last appointment, it actually brought up some other things that felt pretty overwhelming. So I actually abandoned it altogether, to be honest.
Oh, I'm really sorry to hear that. What kind of things did it bring up when you were searching?
Things like fighting over money and yelling, one person throwing things, silent treatment, that kind of stuff. So when I searched those words, it brought out pages about abuse and violence. And I don't know, he's not hurting me, so it's not that, so I don't know what that really means.
Yeah, I imagine, I mean, that must have been really confronting to read things like that. I can see that would have had a real impact for you.
Yeah, it kind of made me think about, our last appointment when you asked about whether I was afraid or safe at home. And is that what you meant by that?
I was a bit concerned. Yeah. And up front, I just want to say, I know that this can be really hard to talk about. So just want to let you know, we can stop talking about this whenever you want to. But yes, this is what I was meaning. And I know words that like violence and abuse can feel really daunting, because we often think that means physical violence, right?
Yeah, exactly.
And so what if we said that actually, that what we're talking about with that kind of abuse and violence is we're talking about things like control, or feeling like we have to change our behavior in some way because we're scared of another person's response, or someone else taking financial control maybe. That, feeling like we're walking on eggshells, similar to what you mentioned last time that you and the kids do. All those things are also not okay, and it doesn't have to be physical violence to be a problem. Those things are counted as violence and control as well.
I guess it's just really hard to hear. Yeah, it's weird to say this, but yeah, it just feels so overwhelming even talking about this. But it also feels kind of a relief. I just kind of feel like, just kind of feels crazy to say that. Yeah.
Yeah, no, and I can understand it feels crazy like that, but I can assure you it's a really normal response to be talking about it in one hand where it feels overwhelming, but also to feel like, oh, okay, someone, you know, I can talk about this now.
Yeah. So what do I do now? I don't want to do marriage counselling or anything until I figure out a little bit more on my own, like my own head, and just, it feels a lot to even make sense, really.
Yeah, no, absolutely. I can understand that. And I can really understand, you know, you wanting to feel like you've got things straight in your head first. If you think it would be helpful, you don't have to try and work that out alone. There are places that you can call, and there's people that you can talk to that could help you figure that out. There's local services in Geelong that you can go to. I know we're in Geelong, so you could go to local services.
I don't know if I want to go anywhere for that yet. Like, I just think I need some time.
Okay, that's okay. That's absolutely no problem. There are, if you know, going somewhere feels too daunting, there are also phone supports that you can access. So there's 1-800-RESPECT, which is a 24/7 number. You could give them a call. You could just talk things through, try and get some of those things out of your head. You don't even have to give them your name if you don't want to. You could just call them anytime you wanted to, if that felt more doable.
Yeah, I think that's probably something I'd be more comfortable with at the moment. And yeah, thanks. I might give them a call later.
Yeah, no problem. You're welcome. Also, just know, I suppose, that you can talk to me about any of this if any of it changes. We've got an appointment booked for another 2 weeks anyway. Would it be okay if I checked in with you again at that time about this?
Yeah, I think so.
Okay. And then again, you know, please don't wait. If things get worse or you start to feel like I don't know what to do next, please do call our reception team and try and book an earlier appointment. That's absolutely okay.
Thanks.
Okay. The only kind of comment I'll make about the ending of that one too is that sometimes I think leaving it in that space where we know that something has happened and that person is not really ready to access a service yet, but we maybe feel like that is something that would feel better for us as a practitioner, is sometimes something that we might end up with in these spaces. And unless we have identified something that is requiring an urgent response for imminent risk or a mandatory report, that is absolutely that person's choice. So sometimes it is, you know, maybe we get a secondary consult from someone, but it is actually then our uncertainty, I suppose, as practitioners to sit within that space. We feel awkward. The final one.
How are we going for time, Emily?
Yeah, I know. Yeah. We'll try and get through this one as quickly as possible.
So let's just race ahead, and we will wrap up right on 8. Let's go for it.
Yep, we'll go. Yep.
Okay.
So again, test results. Okay, so we're talking about stress. So what else is happening? How's all that going?
Yeah, look, things haven't calmed down at home like I hoped. If anything, it's actually getting worse.
Oh, I'm really sorry to hear that. What's happened since I saw you last?
But I mean, last weekend it got pretty intense, but I don't even know if I don't know if I'm overreacting anymore. I don't want to get him into trouble or anything. Yeah.
Okay, that's okay. So look, just so that you know, you're able to say here as much or as little as you want to about this. Whatever you do need to, you know, and want to say is okay with me. I can hold that. Regarding him, you know, being in trouble because of anything that you might say here, just like with everything else we talk about, what we say in these appointments is confidential, and I won't share that with anyone outside of that unless you want me to. The only exception to that would be if for some reason something that you say makes me think, oh my gosh, you and the kids are at really pretty serious imminent risk right now and we need to do something pretty urgently. But to be honest, even then, you know, Rochelle, I'm going to talk to you, Jane, I'm going to talk to you about that before we do it while we're here. So does that sound okay?
Yeah. So last weekend, I guess he had a contract fall through with his business and he got absolutely wasted. He was yelling and ranting. And when I tried to calm him down, because I didn't want the neighbours to hear, or anything like that. He actually locked me out of the house, and I'm so glad the kids weren't there. It would have really freaked them out, actually. And yeah, at least I'm grateful he doesn't go off like that when they are around. But yeah, this is probably the worst it's ever been.
Wow. I mean, Jane, that must have been really frightening. What did you do when that happened?
One of my best friends lives in our street, so I just went down and had a cuppa with them. And yeah, just to kind of let him simmer down. But, you know, even when I was explaining it to her, she said that it sounds worse than other times. And yeah, I just stayed there for a couple of hours, and then I just went home and slept in the kids' bed. Yeah.
Mm-hmm. I mean, that must have been really difficult for you. And yeah, I mean, I tend to agree with your friend. Listening to you today, it really does sound like things are getting worse. And you said that you actually didn't really feel safe enough to stay there, and we're really glad that the kids weren't there as well. But that does make me feel concerned for your safety. And I wonder if it might be a good idea to talk with someone who can help.
Yeah. But who would that be?
So there are a number of local services. There's the Orange Door. It's a sort of a bit of a, port of call. I've got the numbers here and we can call them if you like. We also have a quiet room down the hall. You could call from there instead if you'd rather. I'm more than happy for you to keep talking to me about it as well whenever you need to. But I just, these teams are specialists in the area, and I probably feel more confident in their ability to help you decide what's actually safest in this kind of space. How does that sound for you, though? What do you think you might like to do?
Yeah, okay. I think I could call them myself. But yeah, maybe I could call them from a room so I don't have to do it at home. That would be good. And then maybe would it be okay if we have another appointment like next week? I think that I just feel safer talking to you about this now. And I think I just want to check back in. Yeah.
Yeah, absolutely. Yep. No, I was going to suggest the same thing. So I'm really glad you think that would be supportive as well. I'm going to give reception a buzz now and ask them to take you down to that room and make that appointment for you. And then I'll check in with you after. Okay, 7:59. Yeah, just to get a sense of what it might look like if we're looking at something that's a little bit higher risk, but hopefully that gives you a little bit of a sense of how those conversations might go. We will send out the second case study to you so that you can have that information. Again, we've just got general support services there for both sexual and family violence if you need to provide those supports. But Health Pathways as well has a lot of information about these kinds of presentations and things that you can offer. The next one is also just looking at really just our self-care and just making sure that, again, we recognise that this topic is really difficult. Please do what you need to do. Contact the supports that you have if you need after today or when you're doing this work. But please don't feel like you need to do it on your own. Secondary consults, always call us if you need to. And I think that's it for our bit.
Thank you so much. Well done, everyone. Thank you, Penny, Rochelle, and Mindy as well. Tonight's been a fantastic demonstration for all of our attendees on sensitive inquiry in the space of family, domestic and sexual violence, and using a number of scenarios and patient responses as well, which I think would really help to make this applicable in real world type scenarios. So I just thank and congratulate Penny and Rochelle for your efforts to customise your training tonight to primary care. We know that it's a tough space to do this work within. And we're just reminding everyone to please complete the evaluation if you enjoyed this session, if you got something out of it, because we want to ensure to be able to run more into the future. And we do also encourage everyone to join us for our fourth and final session coming up on the 27th of May, which will really tie in beautifully with what's been discussed tonight. It's specifically on holding patients and providing trauma-informed care over time where patients might not be ready to access specialist services. Thank you so much, everyone. Have a lovely evening.